Imagine a stable elderly patient recovering on a medical ward. Within a span of hours, they become entirely disconnected from their environment. They stop recognizing their family, their sleep cycle inverts, and their attention fractures. They are rapidly losing their grip on reality. Historically, medical staff might note in the chart that the patient has become confused. But confusion is a symptom, not a diagnosis. What is actually happening is a systemic, high-stakes medical emergency. We need to start calling it by its true name: acute brain failure. This slide outlines the sheer scale of the problem. Delirium affects roughly 23% of all hospital inpatients, and as you can see, the burden is even heavier on surgical wards compared to general medical wards. The stakes of missing this diagnosis are incredibly high. Looking at the risk profile here, delirium carries a severe short-term mortality rate in the hospital and a cascading long-term mortality risk that extends outward from 3 to 24 months after discharge. Delirium is a physiological fire alarm. It indicates a lethal, systemic breakdown occurring somewhere in the body, and it demands an immediate, aggressive medical investigation. To identify that alarm, we rely on strict ICD-11 criteria. Delirium requires a distinct disturbance in attention, orientation, and awareness. Crucially, these must represent a sharp change from normal baseline functioning, directly caused by a medical condition, substance, or medication. Time is your primary diagnostic tool. Delirium has a rapid, volatile onset, developing over hours or a couple of days, and fluctuating significantly over a 24-hour period. This immediately separates it from the slow cognitive decline of dementia. We also have to apply specific exclusion criteria. As the diagnostic text clarifies, you cannot diagnose primary delirium if the patient's state is better explained by a typical syndrome of active substance intoxication or withdrawal. Acute fluctuation is the defining hallmark. When a patient's cognition drops off a cliff overnight, you are looking at an acute medical crisis, not chronic decay. To understand exactly why that cliff exists, we use a concept called the cerebral reserve. Think of this as the brain's maximum capacity to absorb physiological stress and maintain normal function before it fails. A patient develops delirium when two interacting factors combine. The first is what we call predisposing factors, the chronic conditions that silently chip away at that reserve over time: extremes of age, cardiovascular disease, existing sensory impairments like poor vision or hearing. Each of these chronic vulnerabilities drops the threshold of what the brain can withstand. Looking at the primary predisposing factors, a pre-existing dementia diagnosis or a past history of delirium are the most critical. These indicate a highly compromised neural architecture. A patient with a depleted cerebral reserve is walking on a tightrope. Their brain is primed for cognitive collapse from a remarkably small physiological push. That push comes from the second half of the equation, precipitating factors. These are the acute, immediate insults that strike the vulnerable system and tip it over the edge. This slide details common physiological triggers: a urinary tract infection, a drop in blood sugar, or mild hypoxia. While easily managed in a healthy adult, they break a vulnerable system. Crucially, polypharmacy, using multiple medications, is a massive precipitating factor. If a patient has mild age-related kidney decline, a new medication might not clear their system properly. That single localized stressor builds up, breaches the blood-brain barrier, and cascades into global neurological dysfunction. The clinical model is clear. Delirium occurs precisely at the intersection where an acute precipitating trigger breaches a diminished predisposing reserve. Once that threshold is crossed, the brain typically fails in one of two distinct behavioral phenotypes. Recognizing both is a matter of life and death. The obvious presentation is the hyperactive phenotype. These patients are restless, highly irritable, and often experience hallucinations, demanding immediate clinical attention. But the second presentation is the hypoactive phenotype. These patients display profound psychomotor retardation, perseveration, and a withdrawn, stuporous appearance. Hypoactive delirium is exceptionally dangerous because it is quiet. It is routinely misdiagnosed as simple depression or sheer exhaustion. Because they aren't causing a disruption, the underlying physiological crisis, the infection or the organ failure, is left entirely untreated. On a busy hospital ward, sudden withdrawal is a massive red flag. The quiet patient is in far more immediate danger than the loud one. When you suspect acute brain failure, Your next step is physical action. Because the symptoms are neurological, but the cause is systemic, a rigorous top-to-bottom physical examination is absolutely mandatory. To rapidly hunt down the hidden trigger, clinicians rely on the Pinch Me framework. You assess for pain, hidden infections, nutrition status, and constipation. Then you verify hydration levels, conduct a strict medication review to catch polypharmacy, and assess their environment for sensory deprivation. This physical checklist dictates your lab work. As the management guidelines show, you cast a wide net. Full blood counts, renal and liver profiles, chest x-rays, all the way through to urine toxicology and EEGs. The golden rule of this investigation is simple. You are not treating the brain. You are hunting for the infection, the toxin, or the imbalance that is actively attacking the body. While you hunt for the biological root cause, you still have to manage the patient's immediate distress. The foundational philosophy here is that environmental management always outranks sedation. The primary strategy is the Hospital Elder Life Program, or HELP. The first step is aggressive orientation, using clocks and family visits to ground the patient. The protocol also requires strict sleep hygiene, early physical mobilization, and ensuring the patient has hearing and visual aids. You cannot reason a patient out of delirium, but by anchoring them firmly to physical reality, you give their brain the necessary scaffolding to survive the physiological storm. Pharmacological interventions have a narrow role. Short-term, low-dose antipsychotics are used solely to manage severe agitation threatening patient safety. They don't cure delirium. Guidelines explicitly warn these drugs must be avoided in specific contexts, particularly alcohol withdrawal or seizures, where they worsen outcomes. Delirium is the brain's final warning siren. By understanding the strict threshold between a patient's vulnerability and an acute trigger, we can look past the confusion and identify the failing system beneath. Treat the root cause, rigidly manage the sensory environment, and never mistake a quiet patient for a safe one.